Okay, well, good evening, everyone, and thank you for joining us for our Moving Forward, the Doctor is in What We Know. This year, Ramaz's theme has gone from Rise Together, and for this year, it's the idea of Ramaz Next Level. And tonight is about the next level. We have an opportunity to share together an educational moment, as we do on these webinars, on these Zoom programs that we have, to continue to recognize that the pandemic is still with us, and that there are people as part of the pandemic that unfortunately have lost loved ones, people who are ill from either the illness itself that continues to linger, and we'll hear about some of that this evening, or those that have the new variant, the Delta variant, that are ill as well. We wish those people a refuah shlema, and the community continues to rise together and also reach the next level of being supportive of one another and caring for one another. Tonight is an opportunity to spend time together, understanding more and learning more. So there will be question and answers. Those question and answers throughout the evening can be placed in the Q&A at the bottom of your screen. And many of you have already sent in questions, and we will address many of those questions this evening. And we just want to remind everyone that we are not going to address personal questions, and also not going to address decision-making for communal issues, whether that's synagogue, school, or your own other communities. Instead, we will talk very, very generically and have opportunity to hear from our experts on the topics that we are addressing this evening. But please do feel free, if those are things that you'd like to address, to reach out. At the end, Dr. Schlesinger and Dr. Shatzkes' emails will appear. They will be happy to answer questions after this webinar. So tonight, our two panelists are, as a return, very popular panelists for us, for the Doctor is in, Dr. Sarah Schlesinger Hirschfield. Dr. Schlesinger is currently an associate professor of clinical investigations at the Rockefeller University and the chair of Institutional Review Board and a senior physician at the Rockefeller University Hospital. She is also, as we like to point out, the very proud mother of Jacob, who is amazingly, I cannot believe it, going to be going into the 5th grade this year. And we are very much looking forward to having a star 5th grader as Jacob is within our midst. We are joined tonight by a fellow Ramaz Parent, Dr. Joshua Shatzkes. Dr. Shatzkes is also claimed to fame because he married a Ramaz alumna, a very, very special woman, Nadine. And we are so pleased that Josh has joined the ranks of Ramaz Parenthood. Joshua Shatzkes is an assistant professor of medicine and cardiology at Mount Sinai, specializing in cardiovascular medicine. He served as the co-director of the strategic planning and operations at the Plasma Collection Center at Mount Sinai during the pandemic. And he has treated hundreds, if not thousands, of patients with COVID in inpatient and outpatient settings. He has been a tremendous help to the Ramaz, KJ, and greater community during the pandemic, and he can speak more to that during his introduction. He also is the proud parent of Simone, who is going into the 10th grade this year, as well as Jonah and Sophia, who hopefully will join the Ramaz ranks one day as well. It is great to have Dr. Schlesinger Hirschfield and Dr. Shatzkes with us, and I hand over for a little bit of an opening dialogue, the program to Dr. Shatzkes to begin with, and thank you all for joining us. Dr. Shatzkes.
Thank you, Kenny. Thank you, everybody who's on the call. I appreciate your attention and coming out today to listen, and also thank you to Dr. Schlesinger. I think we're very fortunate today in that we have somebody clinical and somebody in the realm of basic science, someone who can talk about both ends of what's going on in the pandemic. And so I'm going to stay in my lane today, and I'm going to talk about the clinical, which is what I do. I wanted to begin by just getting two main points across. And I'll begin by saying that I am not a politician. I have no affiliation with any pharmaceutical companies, or I'm not employed. I have no disclosures on that front. And so when I say what I'm about to say next, please know it's completely as a clinician and without any other connections. The vaccine saves lives is my point number 1 through 5. In everything that any of us do in our life, we always start by asking, whether we do it actively or passively, what is our goal? What is it we're looking to accomplish? With the vaccines, we need to start with the following. What we were looking to accomplish as a society, as a medical community, was not to stop COVID altogether. It was to save lives. It was to stop severe illnesses. It was to stop hospitalizations. It is to stop deaths. On that front, the vaccine is succeeding. And I therefore would start with the plea and the urge that if you have not been vaccinated, to please get vaccinated. That is a general statement. If anyone on today has an individual situation, of course, discuss it with your doctor. But on a general level, whether you had COVID or not, please, please, please get vaccinated. Along those lines, I wanted to just address one of the most common questions that I get asked when I'm in the office, which is, what about the side effects? What about the risks? I don't know how many of my patients at this point are vaccinated. It's a very large number. I have seen exactly 0 patients develop a severe long-term illness due to the vaccine. I know that there's reports that are out there in the media. Maybe you've read articles, maybe you've read medical articles. I'm not going to say that there are not cases. I have seen 0. What I have seen from COVID is far, far worse. As a heart doctor, the most common thing I get asked about is pericarditis, which is inflammation around the lining of the heart. I've had a couple patients come in after their vaccine. I've wondered if they have it or don't. I haven't been sure. I've treated it conservatively as I might any other pericarditis patient, and they've been fine. So at least from one doctor's experience, 0 major side effects from the vaccine. And I can tell you that I have way, way more patients than 0 who have gotten severely ill from COVID and who continue to suffer the effects from COVID. The second point I just wanted to pass along as an opening statement is, if you, God forbid, do get COVID, and you are a person that would consider themselves high risk, you're older, or you have some comorbidity that makes you think that you are high risk, that there are options that are still very much available to treat COVID, but you have to be early. And the one that's most important is monoclonal antibodies. And so whether you're vaccinated or unvaccinated and test positive for COVID, even if you're in the early stages and only have mild symptoms, if you're someone who considers yourself high risk, get the monoclonal antibodies. Most hospital ERs in our major metropolitan area have it available. It's not all, but most. At the very least, speak to your doctor. And so those are my 2 introductory statements. And with that, I'll hand off the forum to Dr. Schlesinger if she would like to begin with any comments as well.
Thank you, Josh. It's, first of all, I'm honored to be back. It's lovely to be doing this with you. As you point out, I think we complement each other from really the opposite ends of the spectrum. I think, though, before I start, I think Kenny has something else he wants to say.
I thank you very much, Sarah. I neglected to be thankful, which is always important, to our sponsors of the evening. That is to recognize that these evenings are part of a larger program that the community does. Tonight is sponsored by Gail Propp, in grateful appreciation of Sarah Schlesinger Hirschfield and all that she does for our community, and by Dr. Penny Grant, an alumna of Ramaz. Dr. Grant is sponsoring in honor and loving memory of her sister, Vivienne Grant Esquire. So I just wanted to make sure that everyone was aware, and thank you. I hand it right back over to you, Dr. Schlesinger.
Thank you. So I'm honored to be here. And Gail, thank you so much. That was such a lovely, lovely thing for me. And you know, I'm honored to be back here. I wish that we were all in person. I would be remiss if I didn't say I'm disappointed. In June and July, I really was hopeful that nobody'd want to hear from me at this point, that we would be done, but we're not done. And as much as we would all like to be done, and I am top of that list, we are in so much of a better position this year than we were at this time last year. And as I was preparing for this, I was sort of reviewing my previous notes from, you know, my panic of last spring to my less panic, but still panic of last fall. And the reason that we are in so much of a better position is exactly what Josh said. And as Josh so nicely said, we really do complement each other. And the vaccines, despite the fact that they may not be all that some of us had hoped for, are nothing short of a miracle. And so, as I've said before, long before COVID, I was working on developing vaccines for viruses, primarily HIV, and thinking more about the immune response side, but thinking about the interaction of the viruses and the immune response. But one of my major teaching responsibilities was to teach vaccine development, how a vaccine gets developed. And I have slides, and I look at these slides now, and they've turned on their ear. Not all of them, but many of them have. Because as I think I've said before, the common wisdom was it took 10 years to develop a vaccine. And these vaccines were developed without compromising on safety, by taking risks financially, not medically, but by doing things in parallel, and by putting a tremendous number of people, particularly on the regulatory piece, to make it go much faster. And I think that that's going to change the bar forever for our vaccine development. But when I would teach this course, my first slide, and I teach young doctors who are already trained, they're already fully trained physicians. The first slide I had was, what is a vaccine meant to do? And invariably I would get a whole host of answers. It's meant to prevent infection, it's meant to prevent disease, it's meant to prevent spread of disease, and none of those are correct. The answer is what Josh said. Vaccines, all vaccines, but this one particularly, are designed to prevent death, and also severe disease and hospitalization if possible. But the bottom line is for them to prevent death. The polio vaccine is also designed to prevent paralysis. No vaccine that I know of completely prevents infection, because the way vaccines work is they teach our immune system, and this is the same if you have immunity from a previous natural infection. If you've previously had COVID, you get the vaccine fools your body into thinking you saw the COVID, or you actually saw the COVID if you were naturally infected. You make an immune response. And if you measure that immune response 2 to 4 weeks later, you'll see a very big antibody peak. And then you'll see, if you have the correct test to measure it, cellular response, the T cell response people talk about. But then both of those go away. They contract because your body couldn't keep up having immunity at that level to everything you've encountered in your life. It would be impossible. So the beauty of the immunity response is memory, and these contract. And they're not gone. They're lying there waiting. And then when you re-encounter the COVID, when it hits you again, it takes a little bit of time for your body to rev up that immunity to kill it. So you have this sort of battle, if you will. I at one point had slides of a battle of cells and viruses. I don't know where those are, but anyway, a battle, if you will, to ramp up the immunity to tamp down the virus. And if it's perfect, you don't get sick. You don't feel anything. If it's not perfect, you get a little bit sick. But if it prevents the level of replication that causes severe disease and then death, the vaccine is a success. So the vaccines that we have, both Pfizer, Moderna, and to a lesser degree J&J, but still to a very significant degree, they work beautifully. And they work against Delta. They don't work against Delta as well as they work against the parental strain or Alpha, or I think Beta 2, but they do work really, really well against Delta. And so we are able to rely on them, not 100%, but to a great effect to prevent severe disease and death. And Josh, you can comment on this better than I can, but my understanding from my clinical colleagues is virtually everybody who's hospitalized in New York at this time is unvaccinated.
I don't have exact numbers. Obviously, anyone on here can go look, but data from almost every state, and this is even in the media, where it's not even from actual articles from the state. But I can tell you that I have not admitted anyone to the hospital who's been vaccinated. I have had plenty of patients with the vaccine who have tested positive. Not one of them have needed admission. There are going to be anecdotes, there are going to be stories of vaccinated people who end up in the hospital. I would caution those of you who sometimes hear those anecdotes that those will often be patients who may have mitigating factors. There are certain immunosuppressive diseases, transplant patients, I'm just giving examples, that may explain why a vaccinated person ends up in the hospital. And you may not know that when you hear it secondhand from your neighbor down the hall. But the vast majority across the country, again, I can just speak to my little world, it's going to be unvaccinated patients who are getting significantly ill and unvaccinated patients who are in the hospital and ending up on high levels of oxygen and really getting what we call the COVID pneumonia. And I'd like to just take a moment to talk about that again for a second, because you probably all heard about it last time, but a reminder again of sort of what this does. If you are unfortunate enough to get the cytokine storm, which again, the COVID vaccine does not do this. The COVID vaccine does not contain any COVID virus and will not do this. But if you are unfortunate enough to start out as mildly ill, and then for whatever reason, your body in response to COVID flips a switch and then converts into the cytokine storm, and all of a sudden you get this big inflammatory reaction, that's you going down the rabbit hole. And sometimes that happens early in a course, and sometimes that happens middle in a course, and sometimes that happens later in the course. But then you are talking about being severely ill, ending up in the hospital, and possibly having long-term effects, and coming to see someone like me for what we call long haul symptoms. And so I completely agree with Sarah, and we're agreeing with each other about this because we both support vaccination. You have a significantly decreased chance, a really, really, really decreased chance of ending up in the hospital and severely ill and dying if you get the vaccine as opposed to not getting the vaccine.
So the other thing that Josh mentioned that I think is on my list of things to be extremely grateful for are the highly neutralizing monoclonal antibodies. So there have been a whole bunch of treatments that have been proposed and tested. And, Josh was the person who was in charge of the operations for the collection of convalescent plasma, which seemed like a great idea at the beginning. It was all we had. But highly neutralizing monoclonal antibodies are extremely potent, and they work very well, and they're also very safe. But the key thing about them is they have to be administered early. So they kind of substitute for your pre-existing immunity at a very high and specific level. But once the infection gets going, and certainly once there's any kind of cytokine involvement, they're not useful, and I don't think they'll be administered. Josh, you can correct me, but I think you have to be within 5 days of infection or 5 days of exposure.
What officially got released at the beginning was within 10 days, but the way most places have operationalized it, it's been under 5 days. I was aware of some places that were even saying it had to be within 48 to 72 hours, and some places were more liberal. I think the biggest takeaway is these are life-saving treatments, and most effective as soon as you find out that you're COVID positive. And so they are very easily accessible. If you just go to, again, most emergency rooms, there are some outpatient centers. As somebody who practices in Brooklyn for part of my week, I know that Williamsburg has such centers, and Borough Park does as well. I don't know what's around the city, but I know that I know of at least Mount Sinai's ER. Believe
New York Hospital's ER. I know
New York Hospital's ER, and so these are life-saving treatments, and the earlier you get treated, the better.
And the thing is, so this also has been proven now through very rigorous clinical trials. And in fact, the Regeneron antibody is now under full approval. So one of the questions that I get asked pretty regularly, and I was asked to address here, is what the difference between an EUA or an emergency use authorization is and full approval by the FDA. So these are administrative terms, but they're actually kind of important to understand about how much is known about a treatment. So when there's an emergency, hence the word emergency use authorization, and there is a new illness, or sometimes with a very serious kind of cancer if there's no pre-existing treatment, something that's new and very promising in clinical trials. So it's been tested extensively, but it may not have been tested, the follow-up after the testing may not be 6 months to 18 months, which is what's typically required by the FDA. But where a decision is made, the need is so great that it's worth employing it before that time has elapsed, and all of the data from that time has been reviewed, the FDA issues what's called an emergency use authorization. And an emergency use authorization is very specific. So it tells you what you can use, in whom you can use it, by age and how much. And it's very, very specific. And nobody can deviate from that, or they're not supposed to. Once something has been tested in a sufficient number of people for sufficient length of time, and the manufacturing, which is a tremendously, tremendously complex review. I was talking to a friend of mine who was saying when he worked for a pharmaceutical company and they were bringing their NDA, their new drug application down, they had a truck, a literal truck full of papers. It's that much paperwork, and it is reviewed very, very carefully. One of the things about the US FDA as compared to the EMEA, which is the European Medicine Agency, is they do their own initial review going back to the primary source documents. They don't take the pharmaceutical company's review and sort of rubber stamp it or just survey it. There is an entirely new analysis. And once that is done to the satisfaction of the FDA, that's when what's called full approval is given. And when something is fully approved, a doctor like Josh can use it, what's called off-label. So it will be approved for a label, which will say this is approved for, a very good example of that is the human papillomavirus vaccine. It was approved for use in people 11 to 23 because the clinical trials were done in that group. There was no reason to think it wasn't going to work in a 24-year-old or a 25-year-old or a 35-year-old for that matter. But the FDA gave it a very narrow label because that was how the clinical trial was done. Now, one could argue about the wisdom of doing it that way, but for this discussion, that's how it was done. I received that vaccine as soon as it was approved, even though I was way over 23, but my doctor prescribed it for me off-label because in her judgment, the benefit outweighed the risk and I was willing to take the risk. Now, that becomes problematic because insurance companies often will only pay for what's done on label, but that's another matter. But when we last talked, all of the vaccines were under what's called an EUA. The Pfizer vaccine has now gained full approval for individuals over 16. It's still under an EUA for individuals 12 to 16. And the Regeneron antibodies that Josh was talking about are now also fully approved. So different hospitals can say, we'll give them at 2 days, we'll give them at 5 days. There is no longer such a narrow approval. But that also means there has been an extraordinarily thorough review both of their safety and efficacy at the FDA. So that's also huge progress. And I understand that the Moderna vaccine will probably be granted full approval in a matter of weeks. And so that allows a much more liberal use of it. And I think there are many people who are more comfortable. There were a lot of people who were waiting till it was fully approved. And, like I know at my university, we were required to get vaccinated, but it was waiting for the full approval of the first vaccine. So a lot of organizations, rely on that full approval. It's for sort of say it's kosher. So that was one set of questions I wanted to answer. The other question that is the question that is burning on my mind is when we're going to be able to vaccinate children under 12. So currently, 16 and up, fully approved Pfizer, 12 to 16 still under an EUA. And Moderna is not, none of the other vaccines are approved below 18. Both Pfizer and Moderna have ongoing clinical trials in children 6 to 11, I guess 6 to 12, and then separate trials in children down to 6 months old. Those trials were planned to read out a few weeks ago. But upon review, and I don't know what was in the data, I haven't heard that, the FDA decided that they wanted more safety data, more follow-up, and to expand the number of children in both trials. And so it is unclear to me, though I have tried through several sources to find out when people think they're going to finish enrollment. So if you recall, all of these trials are what's called event-driven. So, and this was the whole problem last year when was the vaccine going to be, when was the Pfizer vaccine going to be available? Was it going to be October, November, December? There is, at the beginning of the trial, when it's designed, all of the people working on it, led by the biostatisticians, agree to a certain number of infections. So they say, okay, we're going to test it in 100,000 people, and we have to see 100 infections or 1,000 infections. I'm making these numbers, I'm pulling them out of my hat, my head, whatever. And then you wait till you have those 1,000 infections. And then and only then you break the blind. And you see, because some of the people received the vaccine and some received placebo, which is, say, think of it as salt water. And you see if all of the infections or most of the infections fell in the group that received the salt water, the vaccine had an effect. If they occur equally in both groups, the vaccine didn't have an effect. So there's no way to know how many events or infections are going to accrue or when they're going to accrue. So that's why the dates are a little squishy. I don't think it's realistic to think that there is going to be an EUA for children 6 to 12 before Thanksgiving. If that happens, I would be very happy, but I think it's unlikely. So I think the challenge that presents us with is having to plan for another school year. And again, Kenny was very specific. And as you know, we never discussed the details of the school because that's not our job. And as Josh said, I try very hard to stay in my lane. And the school's doing a wonderful job, I think, in a very challenging time, and the shul too. And, you know, everybody is making decisions based on risk-benefit analyses. And one of the things that has become eminently clear is it's very important for children to be in school. Unfortunately, one of the things that is less good now than was a year ago, it has become clear, I think we thought that children really weren't getting sick and weren't spreading it. It has become clear that young children do spread COVID. They may be asymptomatic, but may spread it to household contacts. And that's been recently published and is very clear. And Josh, you might comment on it. I think more children, particularly older children, are getting sick this time around than last year. Though I don't know I don't have expertise in that, and I don't know how much of that is just sort of media hype and how much of that is real.
So I take care of adults, and so I don't see kids on a regular basis, and so I can't comment from personal experience. I can say the following. Some of the people on here may know me because I've taken care of a lot of communities, but that includes Jewish communities. And during the height of the crisis, and still now, I get calls from lots of different community leaders or community liaisons who are seeing what they see in their community and are wondering, you know, is that the norm? Is that what I'm seeing elsewhere? Is that what's going on all over the place? So I'm reading, just like a lot of you are probably, that there are places in this country where kids are getting sick, sick enough where they have to go to the hospital. I have been speaking across the board to lots of community leaders and liaisons in the Jewish communities that I take care of. I have heard of plenty of cases of kids testing positive. I have not seen or heard that phenomenon from the people that I am in contact with. I again say that with the caveat that this is secondhand information, but they are calling me about their adults. And so this phenomenon of kids getting sick enough to go into the hospital and being that ill, at least in our communities, I am unaware of it. I am aware of a lot of asymptomatic cases. There is one community that has probably had about 15 to 25 positives, probably for the last 6 weeks. And we have not seen a spike in hospitalizations or deaths in that community. That community does a really good job of vaccinating their older people and their people who have comorbidities. And they're also very good at getting the monoclonals to people who test positive very quickly. And so hopefully that's a model for how it should work. There is, in other Jewish communities that I take care of, a spike in positive cases over the last week or two. I've gotten a lot more calls about where do I get the monoclonals? I've tested positive. This is what's going on. I have mild symptoms, this or that. That's been happening a lot more in other communities. And so I think that trend, if you made me guess, this is a prediction, will continue, especially as we gather even more in the coming weeks for the holidays and as school is restarting. But the key point is that if you're vaccinated, you shouldn't get really sick and shouldn't end up in a hospital. Sarah, I wanted to touch on something that I think we've been asked in the chat, and I'll just address it from a clinical standpoint, and then I think it's a good lead-in for you to talk a little bit about the difference between your own immunity to COVID versus the vaccine. And so we were
natural
asked,
infection versus vaccine-induced protection. Sure.
Yes, and so we were asked the question in the chat about whether I'm a healthy person, I got COVID, but I'm healthy otherwise. Why should I bother getting the vaccine? From a clinical standpoint, I would say this is easy because I don't have a crystal ball. And so I can't predict if you are going to be one of those unfortunate cases. And being that I consider the vaccine to be such a low risk thing for you to get in terms of side effects, I would say to you as a clinician that the risk benefit ratio, which Sarah touched on before, and is the way we really do everything in medicine, is what's the risk and what's the benefit, definitely favors you still getting the vaccine. Because again, I know that if you get COVID, and I did have a few cases of before the vaccine came out and even after the vaccine of people who got COVID a second time, unvaccinated people who got sick. And so, and I've had plenty of young, healthy people who have gotten sick enough to end up in the hospital. And so certainly if you're someone that wants to get monoclonals and you're young and healthy, but you still want to explore that, by all means, talk to your doctor or like I said before, go to your local emergency room. But to me, this is all about risk-benefit ratio. And the risk of getting the vaccine is so much smaller than the risk of what happens to you if you get COVID and end up a long hauler. So with that, I'll transition to Sarah and allow her to talk a little bit about the two different types of immunity.
Right. So Josh, I agree with you completely. And I understand why one might think if one had COVID, why would you take the additional risk of getting the vaccine? So the natural immunity is great, and it includes many different what are called antigens or parts of the virus, but it only rises to say a magnitude of 10. Again, these are made up numbers. If you've had COVID, and again, I would not recommend that somebody who had COVID get vaccinated immediately after they recover. I think the recommendation is 90 days.
90 days.
90 days.
Current recommendation, yes.
That's the current recommendation. So I think 90 days is eminently reasonable. But after 90 days, the immunity starts to wane. And the problem is now that people who had COVID a year ago or 6 months ago, the Delta variant is different. The vaccine is very narrow. It's not nearly as broad, but it induces immunity that's way higher, logs higher. So you may have seen the recent thing in the newspaper that the Moderna vaccine induces antibody, like I think 3 times that of the Pfizer vaccine. The Pfizer vaccine induces antibody 10 times that of natural infection. And it's to one very specific antigen or epitope called the receptor binding region. And that's where the virus clicks onto the cell. And so the level of protection that you get from being boosted from receiving the vaccine after you've had COVID gives you immunity that's likely to be higher than anything else. In the laboratory, it's very clearly better by a whole lot of parameters. And there are studies now from Israel that people who were infected and subsequently vaccinated are the ones that are getting sick the least. So if you have had, in a way, the good fortune of God getting COVID, getting better, and not being sick, I would say 90 days later, get vaccinated so you don't get sick again and you don't risk the long haul symptoms. As I understand it, and again, I refer to Josh on this, but from what I've heard, and I have friends, who are physicians who got it, who have long COVID, and it's very, very unpleasant. And there's no clear treatment for it either. And so it's really something to avoid. In addition, by getting vaccinated, you prevent the likelihood that you're going to spread it to somebody else to a greater degree than if you don't. And as Josh said, the vaccines are very, very safe. What I would also say, though, what I'm not sure about is if people who've had COVID, I know in Israel, people who've had COVID are only getting 1 shot, not 2. I would recommend getting 2 shots here so you're fully vaccinated, so you can go into restaurants and travel and do all the things that allows you to do. But I'm not sure that those people need the 3rd shot that is now being talked about. And so there are 2 other areas that I want to address. And the first that always comes up is people who are pregnant. And so the initial recommendation was sort of wishy-washy about whether pregnant people should get vaccinated. Now the recommendation is 100% clear that pregnant women should get vaccinated for their own benefit, because there is much higher morbidity and mortality in the later trimesters of pregnancy. Now, the CDC and the WHO recommendations are just flat-footed, but my own personal feeling is, and I obviously am not giving anybody medical advice, but having had 5 children, in the first trimester of pregnancy, I wasn't drinking coffee. I was taking like a tiny little sip of Shabbos wine. I wouldn't take any vaccine in the first trimester of pregnancy if I could avoid it. So I would recommend, if one is considering getting pregnant, to get vaccinated in advance. And if one finds oneself pregnant and not vaccinated, I would personally wait till the end of the first trimester and then immediately get vaccinated, because the morbidity to the mother, the risk to the mother increases as the pregnancy goes on.
Sarah, can I
please.
interrupt for a moment? I've had multiple pregnant patients in the hospital that I've followed, and it's been scary and devastating to watch, because you know that the person in the room is first of all, these are young women, right? And they're for the most part, all the ones that are coming to the top of my head were healthy. And knowing that when I walk in that room, there's 2 people at risk.
2 patients there.
There's 2 patients, and I am not an OBGYN, but knowing what I knew about COVID and knowing the stuff that I'm worrying about for the adult in the room, it's not something you want to go through. So again, these recommendations are really very clear at this point for pregnant women and for nursing women, but certainly for pregnant women, and they're from all the respected organizations, and it's being universally recommended. You don't want to end up in the hospital as a pregnant woman with COVID. It's way worse than whatever you're scared of from the vaccine.
For sure.
But I've watched it happen, and it's been devastating.
I can't even imagine how terrible that must be. And, and of course, women who are pregnant may have other children at home. I mean, the whole thing is just get the vaccine. But the question of the booster and who needs to be boosted and when they need to be boosted and with what they need to be boosted, I see a whole bunch of questions about this. And so they're clearly, somebody says that Israel is showing that prior COVID infection is more durable than the vaccine. That's correct. It lasts longer, but it is not, the magnitude isn't as great. But the combination of prior COVID infection and the vaccine is the best. There is just no question by every metric in the laboratory, clinically, in the population studies. If you've had prior COVID and then get vaccinated, you're really good. And that's, I haven't had COVID. I've been vaccinated. And I have many friends and family members who are in various situations. And the people who feel the safest, who should feel the safest right now, are those who've had COVID and subsequently been vaccinated. And I think that there's just no question about that. And the question of the 3rd shot is a really tricky one. And the reason that I say it's tricky is this. We'll put the global health issues aside, right? So there's a whole discussion about whether it is reasonable for people to be getting a 3rd shot when so much of the world hasn't received any shots. And I can have that discussion, but I don't think this is the correct forum. And right now here in the US, the vaccines we have are going to expire and they're not going to be given to anybody else. You know, they're not going to go to Africa. They're not going to go to South Asia. They're going to expire here on the shelves unless they're used. And one could rue the planning of that, but that's the situation with which we're faced. So there are two different groups of people, and I think it's really important conceptually to separate this. I think this is where a lot of the questions come. There are people who are immunosuppressed for one reason or another, and you may not know, you may know people, but you may not know that they fall into these categories. As Josh said, somebody who's fully vaccinated but is a transplant patient, it's been very well documented that those people, because they're getting immune suppressives to allow their body to tolerate their transplant, just didn't make good responses to the vaccines. They just didn't make the response that was necessary to protect them. So they aren't protected by the two shots. The third shot, for whatever reason, the data looks like the third shot in a large percentage of them provides significant protection. It's enough of a stimulus to do that. There are people who are immunosuppressed because they're on steroid therapy for another reason. There are people who are immune suppressed because they're actively being treated for a malignancy. All of those people likely didn't make a good response to start with. And so those are the people who should get the third shot as soon as they can. Those people are not adding to a response, they're making their initial response. So that's one group of folks. And those people, the third shot's been recommended and they are available now. You can go get them. I've taken family members to get them in the last week with ease. I mean, the difference between, another thing to be grateful for is, you know, rather than standing in line in some huge public facility, we went to a very lovely local pharmacy on Madison Avenue and it was done like that.
Sarah, I think we should say that these are exactly the same shots.
Exactly.
Prior
Exactly.
vaccine that you've received. And so I think a lot of people ask me in the clinic, is this something different? Is this now better? Is this now have the Delta covered? Better than this is just, you're boosting your immune response. And it is the same exact shot that you got the first two times. There is no reason scientifically that it should do anything bad to you. So if you're wondering, should I or shouldn't I, and you're in that group of people who are immunosuppressed, of course, speak to your doctor, but you're really just stimulating your immune system to have a response that it may or may not have had before.
Right. I put those people in the same group as the pregnant people. Please go get the shot.
But by the way, my wife texted me as we're on here to make sure I clarify that the people in the hospital were pregnant women with COVID. I have not had a single pregnant patient with vaccine end up in the hospital. Pregnant patients with COVID have been sort of what's been scary. Nobody with the vaccine. I also want
That's a very good important clarification.
I wanted to touch on a little bit about the long haulers, which again is, even if you don't get sick enough to require the hospital, there are plenty of us, plenty of people who have gotten sick enough that they're trapped at home for a couple of weeks and they really get beat down by the virus and they continue to suffer. And so again, I'm a cardiologist, but I also do practice internal medicine for some of my patients. There are things that I've tried. I won't go into detail and here. They're all normal medications that are used for other conditions that have some sort of anti-inflammatory. And there's things that I'm trying in different patients who are suffering, patients who I wonder if they might have residual pericarditis from COVID. There are patients coming in with continued fatigue. We're talking about even a year and a half later from some of those people who first got COVID in March of 2020, fatigue, joint pains, inability to exercise as much as they want, shortness of breath, chest pain, the long haul syndrome, which in my opinion is going to be, I mean, there's probably decades worth of study that's going to need to be done to figure out why this virus is doing this particular reaction and just absolutely destroying people, not just for a couple of weeks and then they recover, but they continue to feel the effects for so long. Those symptoms are really not trivial. And it at least, again, empirically, just from my patients so far, the people who are getting it, who are vaccinated, they are not getting those symptoms. And so certainly if you are a long hauler, you should speak to your doctor. There are things that people are trying, ideas that different doctors are trying. There are studies ongoing. I know this because I read about them, to try to figure out how we can make long haulers feel better. But the takeaway on this particular point is that it's just such a horrible sort of syndrome to have if you get COVID. And I just have not seen that with the vaccine. Certainly I myself got sick for about 14 hours after my second shot. I know a lot of you hear stories about the vaccine and, oh my God, this person was sick for 48 hours, or this person felt bad for 5 days. I've heard, these stories from a couple patients. The longest one I got was what I just said, 5 days. Somebody said they didn't really feel back to themselves but for 5 days. And I said, okay, I can deal with 5 days. If you didn't feel well for 5 days, that's fine with me. Most people feel sick for anywhere from, if you get a reaction. I didn't get a reaction to the first shot. The second shot, I was down for the count for about 14 hours. Most people get it for about 24 to 48 hours. And then amazingly, it all just disappears. It's really quite a phenomenon to go through.
I have to tell you, Josh, not to overshare, but I got a little sick from the first one, but I was quite sick with the second one for about 48 hours. And then it was done. It was phenomenal. It came and it went.
Yeah. And so I bring it up as a means to say that if you think that, well, I'll get through COVID and I'll be fine, and I'd rather that than take my chances with the vaccine, I may sound like a broken record, but that's really the reason I agreed to come on here today, is because I want this point to be as clear as possible. I would rather you think the other way. I'd rather take my chances with the vaccine than risk ending up having to go see Dr. Shatzkes or anyone else, or ending up in the hospital with COVID that's gotten me very, very sick.
I agree 100%. And I want to just mention two other things about the third shot. So the third shot for people who are not immunocompromised is a different matter, right? Josh, we just lost your, there you are.
I'm back.
The third shot is now, as of, I don't know when, it was last week sometime, the federal government has approved a third shot for everybody who received the first two as of September 20th. And it originally was 8 months after your second shot, and now I think it's been changed to 6 months. And that's based a lot on what's being seen in Israel. And, a third shot is not the same. A third shot for somebody who made an immune response is not the same as a third shot for somebody who didn't. So I wouldn't recommend, nobody's recommending, it's not even approved, to get it immediately. You should wait the 6 to 8 months, depending on what the recommendation is. But that's, again, the same shot that we got for all the others is showing improved protection against Delta because of the increase in the magnitude of the response. So it's not a different response. And several people I saw in the chat, and people asked me, well, shouldn't we wait to get a booster for that's specific for the Delta variant because they've heard they're being developed? They are being developed, but they're probably not going to be available till well into the winter. And I think the hope was that this is going to be like a flu shot. You'll get it annually. And the new one, the annual one for this year, would include Delta. But the timing, the virus had something else on its mind. And the timing of it is not such that that's going to work out. So for now, the same, what's called a homologous, or exactly the same third shot is what we all need to do. Which brings me to two other points that I want to make. And that is that this is not the only virus out there. And I got on the, when we talked about this a year ago, I reminded everybody, you need to get a flu shot. And you need to, people have asked, you probably don't want to get them at the same time. You need to space them out probably at least by 2 weeks, Josh. Is that I think that's what's currently recommended?
Yeah, I have been recommending to my patients, and I'll let you get back to sort of what you want to say, but from a clinical standpoint, especially since we worry about sort of a reaction or side effect,
very good.
If you have a reaction to either one of the shots, you want to know which one you had a reaction to. There are some patients who are have allergies, like for instance, to the flu vaccine. If you get them at the same time and you have some sort of reaction, you're not going to know which one caused it. So simply from a practical standpoint, clinically, but my understanding, and you can correct me if I'm wrong, is that from an immunological standpoint, it doesn't matter if you get them at the same time. mainly helps me as a physician who's taking care of you, and you as a patient, in case you do have not a reaction like where you get like flu-like symptoms, but an actual allergic reaction to something in one of the vaccines, which again, it's much more concerning. My understanding is to the flu vaccine.
Right, the flu, lots of flu, the flu vaccine, and that's a whole nother discussion for another evening. And I have a whole screed about this. Our flu vaccines are dreadful because they're very old. They use old technology. They're made in actual eggs. So this RNA technology is going to revolutionize our flu vaccines, I think, but it hasn't done it yet. So the vaccine that we're going to get this year is actually made in an egg from a chicken. So if you're allergic to eggs, you can't get it. Like, don't even try. But so many.
That's the flu vaccine.
That's the flu vaccine, not the COVID vaccine. COVID vaccine has nothing to do with eggs. So I hear people say, well, I can't get the flu vaccine because I'm allergic. I'm like, but it doesn't apply to the COVID vaccine. It's completely different.
Yeah.
And there are very few people who are allergic to the components. There are a few, but not too many. So it's important to get the flu vaccine. And perhaps most importantly, for our children, it's important to keep up with their regular vaccinations. So when all of this started in March, my own view, my son Jacob, who I'm always talking about, and probably when he hears this will be mortified, his birthday is March 19th, and he goes to the pediatrician in March. And so COVID started, and his pediatrician's appointment was, for around his birthday. We didn't go. I thought it was riskier to take him to the pediatrician's office at that point for his routine visit. He didn't need any shots, for her to look at him and see that he's growing. It's like, we're not going. This year, he needed shots, and this year we went. And he got them, much to his dismay, but he got the meningitis vaccine. And it's really important, again, a risk-benefit determination. Our children's vaccinations protect them from a whole host of dreadful illnesses: mumps, measles, rubella, meningitis. I could go on, but you don't want to miss those vaccines either. So it's really important to keep up with all of that. As much as it seems we're at a time of, sort of out of time in a way, it's gotten to be too long to stop everything. So we have to be really mindful of keeping up with those things. And the flu shot and the other vaccinations as well. So in terms of when somebody with a healthy immune system who got 2 shots should get vaccinated, it's for the 3rd shot. Again, the risk is very small. The side effects from the 3rd shot are much like that from the 2nd shot, is what's been being reported. And since the vaccines are available, everybody should just sort of do it, I think, in the interest of keeping the spread down in the community, with the exception of people who've had COVID. If you had COVID and then were vaccinated, my own personal view is your immunity is so good from what we can tell that it's unlikely that you really need a 3rd shot. It's not going to hurt you to get one, but I don't know that it's necessary. The people also ask, is it better to mix and match or get the same shot? Scientifically, there are reasons why mixing and matching might be a good idea. But from a practical point of view, the only thing that's approved is getting a 1/3 of the same shot. So that's what people are going to do. There is also the issue of the J&J vaccine, and new data just came out that people who get a 2nd shot of the J&J vaccine have a huge increase in their immunity. There's also experimental data showing people who got the J&J vaccine and get boosted with Moderna or Pfizer have a really good response. J&J is in the process of filing that paperwork. So stay tuned. People who got J&J are going to, of everybody, will need the 2nd shot the most.
So Sarah, we're coming up, I think, to the closer of.
Oh my goodness.
Yes. So I'll, if it's okay with you, I'll start with my closing thoughts and then hand off to you to finish it off. And again, I thank everyone for coming on tonight and for listening. And certainly happy to engage with anyone afterwards. I'll close with this thought. I don't know what it's going, and it's very similar to the way Sarah started. I will be the first to admit what I don't know, and I don't know what's going to happen exactly next with this virus. So I wanted to come on today and just say what I do know and what I am seeing. And along the lines of how Sarah started, where we are now, as opposed to this time last year, is so remarkably better. And it all just comes down to advances that we've made in such a short time, specifically to both vaccination and to treatment. And so I think take heart in that we've made this much progress so far. I think COVID may still throw us for a loop, but I don't know that for sure. We may continue just on an upward trajectory, or there may be bumps in the road. I think just, trust in your physicians, trust in yourself, and certainly listen to people who really know what they're talking about and don't just go off secondhand information and trying to figure out what to do. And in closing, I say again, vaccinate. And if you do somehow get COVID, go get the monoclonal antibodies.
I couldn't agree more, Josh. I think that what has been accomplished scientifically and medically with the vaccines and the monoclonal antibodies are nothing short of a miracle. But I would also remind everybody that in addition to getting your shots, there are other viruses out there. So the same things, there's a resurgence of respiratory syncytial virus, which is a respiratory virus that's especially difficult for children. And that actually lives on surfaces. So again, one of the things that's vastly improved is I'm no longer afraid of my groceries, and our spare bedroom is no longer a quarantine for all packages that come into the house. I laugh when I think about that, but that was, I spent a fair amount of time washing down packages, last spring. But the things that protected us before we had the vaccines and the monoclonal antibodies are still tried and true and really work. And that means wearing a mask. I still have my masks, wearing a mask, washing your hands, 20 seconds, 2 courses of happy birthday. It's not intuitive. And perhaps most importantly, staying home when you're ill. One, again this year, particularly with Delta, if you're a little bit sick, don't go to school. Don't send your kid to school. Don't go to work. Stay home. And if things persist, get tested. And so I think if we continue to do those things, and as Josh said, get vaccinated, and vaccinated, I hope by this time next year, we're not going to be having this conversation again. With that said, Kenny asked me to predict, if that's the right word, a little bit about what I thought was going to happen. And again, as Josh said, nobody knows. I didn't think this is where we were going to be at this point, honestly. And I was more optimistic. I am ever an optimist. But this is not my opinion. And again, as Josh said, it's really important to rely on scientific and medical expertise and not go down the rabbit hole. And I have colleagues who are truly the world's experts in this, virologists, one of whom won the Nobel Prize last year. And what they have suggested from the beginning is that, as I've said more times than I can count, all pandemics end. And I can go from ancient Greece till now and describe a variety of them, as my children will be happy to tell you, but I will spare you that. But what happens most of the time is the virus or the bacteria in question becomes part, it's not that it goes away. It becomes what's called endemic, which means it becomes part of the viruses that we live with. And a wonderful example of this was a dear friend of mine cloned the 1918 flu from autopsy material. This is like 25 years ago. And when he was proposing to do this, people came to him and said, don't do this. You're going to create a superbug, and our enemies, the Iranians, are going to get it, and they're going to infect people, and there's going to be another pandemic, and you're going to be responsible. And there were several labs working on it, and he said, we got all the ethical approvals, we have to go ahead, we're going to do the best. He wasn't making it, he was just learning what the sequence was. And what it turned out was, it was a strain of flu that we all get all the time. It is in our current vaccines. It was likely no more virulent in 1918, it was just that human beings hadn't seen it. It made a jump from probably from pigs, from either pigs or birds, but likely from pigs. And it was new to us. And that was why it killed more people than World War I. And this virus, wherever it came from, which again, a discussion for another day, is new to the human experience. And what's going to happen eventually, probably, is that it's going to become, there are 4 currently circulating coronaviruses that we get that cause basically what are colds. And it will become one of those. and some people will get sicker, but most people will have immunity. And that's what's being predicted. Now, how long that's going to take and what's going to happen between now and then, that I don't know. But I have it on, I think, very good scientific authority that that's the most likely path that we're headed down. So we have to be patient, which is hard, and we have to have fortitude, which is perhaps harder, and do the things that Josh said. Vaccinate, vaccinate, vaccinate. Wear your mask, because those work too, as unpleasant as they are. They're not the end of the world. We in the medical world, you know, I did some surgical training and I wore a mask all the time for years. And, you know, we'll get through. And with that, Shana Tova to everybody. Thank you for your attention. You know,
Thank you, Sarah. Thank
else?
you, Josh. Thank you both so much for your expertise, your time, your care, your really bringing us this very, very essential message, especially as we enter into the Chagim. This is so important, and I am sure for many good reasons, people are going to ask to have the two of you back. We are going to share, with your permission, I know you gave us your permission, in tomorrow's email that will go out, the opportunity to be in touch with you, both Dr. Shatzkes and Dr. Schlesinger Hirschfield, so that people who have additional questions that are personal, they can reach out. I thank all of you for being on this evening. I wish you a chativa v'chatima tova, happy, healthy, with an emphasis on health again for this year. And we all want to join together as a community and hope that our tefillot, our prayers will be answered as we enter into the high holiday season. Wishing all of you a good night and thank you for joining us. Good night.
That's about.
good night, Shana Tova. Thank you, Kenny.
Thank you.